Good morning, colleagues. Today, you're going to see a hands-on imaging test recorded on video. We'll perform it with a high-end Sonosite PX Pocus device. We'll look at left ventricle systolic function indices. We place the patient in the left lateral decubitus position. We apply the probe to the second parasternal intercostal space with a transducer marker pointing to the patient's right shoulder. You should rest the probe in your fingers and hold it down with your thumb. Try to be as comfortable as possible. Remember, the patient is now in the left lateral decubitus position. We'll start with a parasternal long axis view of the left ventricle, adjusting the image depth to 13 centimeters, which is usually the best option for this view. This is a parasternal long axis view of the left ventricle. Visually, the patient, who does not have a history of cardiovascular disease, has a normal systolic function. Let's keep going. Still on a parasternal long axis view of the left ventricle, we'll look at the mid-systole. We'll zoom in to perform one of Pocus and critical care ultrasonography most important measurements, that is, measurement of the left ventricular outflow tract diameter. We're going to measure the aortic annulus in inner to inner edge to find out the diameter of the left ventricular outflow tract, whose value is approximately 23 millimeters. Please remember that then you will have to convert outflow tract diameter into outflow tract area, so that when you multiply it by the aortic VTI, that is, velocity time integral, which we measure in the apical 5-chamber view, you will be able to obtain the stroke volume. We've frozen the image at end diastole at the Q wave of the electrocardiogram, that is, when the left ventricle shows as big as possible, and we have a two-dimensional B-mode image in which we've measured the left ventricle end diastolic diameter, which is normal, 48 millimeters. Please remember that in men it is normal up to 59 millimeters, while in women it is normal up to approximately 55 millimeters. Still on a parasternal long axis view of the left ventricle, we'll switch to M mode. As perpendicular as possible to the left ventricle long axis and above the mitral valve plane, what we call level 1. On the right side image of the screen, we can measure the end diastolic diameter and the end systolic diameter. In B mode, this patient's end diastolic diameter was 48 millimeters, to which we can compare this new measurement. In measuring end diastolic diameter in M mode, the value that we get is very similar to B modes. Now we measure the end systolic diameter. Our ultrasound device is using fractional shortening to derive ejection fraction with the Teichholz formula. We have a fractional shortening of 38% and an ejection fraction of 68%. Please remember that the normal value of fractional shortening is 28%. We now move on to another left ventricular systolic function measurement, E-point septum distance, that is, the distance between the E-point of the anterior mitral leaflet and the interventricular septum, still on EM mode and above the mitral valve. We move to level 2. As you can see on the screen, we measured the distance between the septum and the E-point of the anterior mitral leaflet, which has a normal value of up to 7 mm. In this patient, it is of 5 to 6 mm, a normal E-point septum distance, which suggests that his left ventricular systolic function is preserved. Without changing the transducer's position, we rotate it clockwise to make the marker point to the patient's left shoulder. In doing so, we will find this midventricular short axis view where we can see the papillary muscles. We may freeze the image at end diastole or at end systole. With the image frozen at end diastole, we'll use a measurement instrument of this device to obtain the left ventricle end diastolic area in a short axis view. This way, we will be able to obtain the fractional area change, which is another way to assess the systolic function. Please note that we are measuring the end diastolic area of the left ventricle by tracing the endocardial border, living inside the papillary muscles. This is the left ventricle end diastolic area. Let's freeze the image at end systole. We can see that the left ventricular cavity size is smaller now. Let's use this device's measurement instrument again to obtain the end systolic area by tracing the endocardial border. This measurement is highly recommended for critical care areas and Pocus as it has a very low inter-observer variability. The fractional area change is 49%. The normal value is over 40%. Thus, we have another indicator in addition to our visual assessment and the E-point septum distance that suggests that our patient's systolic function is normal. Still on the short axis view position, by lowering the transducer cable, we'll be able to go through the different short axis views, from the mitral valve view to what we can see now, a short axis view of the great vessels, on which we have the aortic valve in the center of the screen. Above it, we can see the left ventricular outflow tract. Let's zoom in over the pulmonary valve. We can thus see the left ventricular outflow tract by using pulsed wave Doppler over the pulmonary valve plane. Furthermore, we can see the pulmonary valve flow velocity pattern. Which is normal. There are no cardiac notches, neither end nor mid-systolic. We may also want to obtain the pulmonary valve peak flow velocity, acceleration time, and velocity time integral. This device has measurement tools that enable us to do all that. How do we do it? We're now tracing the pulmonary valve flow velocity pattern. Note how the machine obtains the pulmonary valve velocity time integral, or VTI, which is 16 centimeters. We are now measuring pulmonary valve acceleration time, which is normal, 133 milliseconds. Less than 100 milliseconds would suggest that it is likely that there is an increase in pulmonary vascular resistance. Let's go back to the short axis view of the great vessels. We lower the transducer cable from the previous mid-ventricular short axis view, which is the one we see now, with the papillary muscles. A mid-ventricular short axis that enables us to see the position of the interventricular septum, as well as assess the left ventricular systolic function and whether there are segmental motility disorders. Here, with M mode, we can also see the left ventricle diameter and thickness values. Let's go to the apical views now. We slightly lateralize the patient, palpate the apex beat, and apply the transducer to the left ventricular apex beat with the marker pointing to the bed. We get this apical 4-chamber view, where we can see the size ratio between left ventricle and right ventricle. We can now measure the left atrium's area and volume with this device's measurement instrument. We can trace the atrium at its biggest before the mitral valve opens to obtain the area and volume of the left atrium. They are normal, but whereas the area reaches up to 20 centimeters square, the volume value is a bit higher, which is useful, especially as a prognostic index. In order to obtain the volume, let's go to a 2-chamber apical view by rotating the probe counterclockwise. Let's trace the left atrium to see its volume in this 2-chamber view. The device will use the Simpson method to measure the left atrium volume, which is 62 milliliters, and needs to be indexed to the patient's body surface area. The normal value is up to 34 milliliters per square meter, so this patient's left atrium has a normal volume. Moving to the apical 4-chamber view and activating M mode at the lateral mitral annulus, let's measure the mitral annulus plane systolic excursion, or MAPSE, which is over 18 millimeters, a normal value. It is an indicator of the left ventricle longitudinal contractile function, which is very relevant in critical care areas. Now, we measure the septum annular plane systolic excursion, or SAPSE, whose normal value is 10 millimeters. As you know, this enables us to assess the longitudinal function of the left ventricle subendocardial fibers. The value of this patient's SAPSE is 15 millimeters. So, all the systolic function indicators of this patient are consistent with our visual assessment. Let's switch to M mode and move to the lateral tricuspid annulus to measure the tricuspid annular plane systolic excursion, or TAPSE. TAPSE is another index to assess the systolic function, in this case of the right ventricle. Its normal value is over 16 millimeters, and we use it to assess the longitudinal function. The value of this patient's TAPSE is almost 23 millimeters, which means that the longitudinal systolic function of the right ventricle is preserved. If we pull the probe cable a bit, we'll start to see the left ventricular outflow tract. So we now have an apical 5-chamber view. By using pulsed wave Doppler above the aortic valve plane, we can get the velocity time integral, or VTI, of the left ventricular outflow tract, which, together with the left ventricular outflow tract diameter measurement that we did before with the parasternal view, will enable us to obtain stroke volume and cardiac output. To do so, the device converts outflow tract diameter into outflow tract area. The outflow tract area is multiplied by the aortic VTI. The normal value of the aortic VTI is 20 centimeters, which may vary due to a number of reasons. We're now tracing the velocity time integral, or aortic VTI. Its value in this patient is slightly below 20, almost 20 centimeters. We can obtain the patient's heart rate with the visual tool of the machine and without an electrocardiographic signal, that is, by marking 2 systolic peaks. The device can then identify the heart rate and calculate the stroke volume, which is 80 milliliters per beat, and the cardiac output, which is 4 liters per minute. As we can see, hemodynamic assessment is a key tool in attending any critical care patient in Pocus and in critical care echocardiography. Some devices can automatically obtain the aortic VTI, which is very useful to get mean values quickly, especially when the patient has arrhythmias such as atrial fibrillation. If we calculate aortic VTI manually, it should be noted that it is necessary to take between 3 and 5 measurements to get a mean value, which reduces the inter-observer variability of the measurement. This is once more an aortic VTI tracer envelope, but in this case, we're testing the device's automated VTI measurement instrument. When the signal spectrum is sharp, the result of the automated measurement is very similar to what we may do manually. If we apply continuous wave Doppler with the same view, we can get the flow velocity across the aortic valve, which in this case is normal, less than 1.5 meters per second. In some patients, it will enable us to identify aortic valve stenosis very quickly, as this velocity will exceed 3 meters per second. We have zoomed in, and there is an apical 4-chamber view. We've frozen the image at end diastole, and we will trace the endocardial border, the interface between blood and endocardium at end diastole, so that the device can derive the ejection fraction with the Simpson method. The machine tells us that the end diastolic volume is 124 milliliters. It also informs us of the length of the left ventricle. We've now frozen the image at end systole, and with the same instrument, we're tracing the endocardial border at end systole, which will enable us to obtain the ejection fraction. The value of this patient's ejection fraction, calculated with Simpson method at a 4-chamber view, is 65%. If we want a more accurate measurement or the patient has segmental motility disorders, we'll need a 2-chamber view. As we've mentioned, we get it by rotating the transducer counterclockwise. So we do the same measurements. Left ventricle volume at end diastole and then at end systole. Now the device tells us that the length of the left ventricle has not changed significantly, no more than 10% with respect to the 4-chamber image, which means that the views are consistent. So, we've obtained the ejection fraction at a 4 and a 2-chamber view, and we'll keep the mean value. That is to say, we've measured the ejection fraction with the biplane Simpson method, which is the most accurate. The value is approximately 62%, which is of course consistent with the visual assessment we had made of the systolic function of this patient and with the indices that we've been implementing up to here, including fractional shortening, fractional area change, E-point septum distance, MAPSE, SAPSE, and the ejection fraction calculation with the Simpson method. Let's review the apical views. From the apical 4-chamber view, rotating the transducer counterclockwise, we will get this apical 2-chamber view. And if we continue rotating it, we will get a 3-chamber or apical long axis view, where we can see the anterior septum and the inferolateral wall. Thus, these views are crucial in assessing segmental motility disorders of the left ventricle. We are back at the apical 4-chamber view. Please remember that with this view, we will be able to assess both the patient's systolic and diastolic function. And also, as we've seen, measure the left atrium volume. We are measuring the basal diameter of the right ventricle at end diastole from the interventricular septum to the free wall. The normal value is up to 42 millimeters. Let's finish our test with a subcostal view. He's a young patient. We ask him to flex his legs and take a deep breath to get a subcostal 4-chamber view. The probe marker is pointing to the left. The transducer is applied below the xiphote process. When we rotate the transducer to bring the marker up, we'll start to see the left ventricle short axis views, as well as the inferior vena cava, which we can see on the screen. By tilting the transducer, we get this bicaval view, where we can see the mouth of both the superior vena cava and the inferior vena cava. Now we apply C mode to the superior vena cava and its mouth at the inflow to the right atrium. This is a subcostal bicaval view. Subcostal views are sometimes the only ones that we can get, especially with patients on mechanical ventilation. Finally, let's get a suprasternal view by asking the patient to extend his neck and turn his head contralaterally. We apply the transducer with the marker pointing towards the patient's left shoulder. We see this long axis view of the aortic arch. The great vessels appear, and with pulse wave Doppler we can assess the flow velocity pattern at the aorta. Still proximal. We see the systolic flow and a slightly low diastolic flow velocity, especially at end diastole. If we apply continuous wave Doppler with the same view, we'll also be able to assess whether the patient has a coarctation of the aorta. Thank you very much. My name is Pablo Merlo. I'm a heart and echocardiography specialist, and I hope that you found helpful this video on the systolic function or left ventricular systolic function indices in Pocus and critical care echocardiography.